Hi, welcome to BariNation, where we support the bariatric community with humor, humility, and honesty.
You've just tuned into a podcast that welcomes you into a community, a resource center, and a safe place that powers your journey towards personal wellness.
Our goal is you leave us today feeling hopeful, inspired, and ready to live your best bariatric life.
Hey, BariNation, it's April. If you are watching or listening to this podcast episode on September 24th, 25th, 26th, or even the 27th of 2025, it is not too late to join our free virtual BariNation walk team, where we're going to come together as a community and stomp out the stigma that so many of us can feel when we start to treat the disease of obesity. If it's after September 27th, it's not too late. There could be an in-person walk happening close to where you live. Linked in the show notes of this episode is information where you can either join our free virtual walk team or register for an in-person walk that's coming up. The Trio Foundation is raising awareness and funds to support critical obesity research that can make a positive impact on my life and on yours. So join us this year and stomp out the stigma together. Open up those show notes, click that link. I hope I move with you soon. Hey, BariNation, it's April. I am so excited for you to meet today's guest on the BariNation podcast. Her name is Dr. Emma Patterson. She's one of the most well-respected researcher, obesity medicine specialists out there. She's been practicing laparoscopic bariatric surgery for decades. Today's conversation is about a vitamin deficiency that some bariatric patients can experience. The topic can be a little bit scary, and I just want to make sure that you know that the reason we're talking about this is that no matter where you are in your journey, you're just more aware of the importance of vitamins in our bariatric life. This podcast episode is not medical advice, and if you choose to make any changes to your current medical situation, consult your doctor, your surgeon, and your care team. All right, friends, let's dive in to this very important episode. Hi, friends. Welcome back to the BariNation podcast. Today, I have the honor and privilege to interview somebody that I've gotten to know a little bit these last few years, Dr. Emma Patterson. Hi, Emma.
Hey, thanks for having me today.
Oh, I'm so excited. Every time I get to talk with you or hang out with you, I learn something new, and I always leave with a smile. So
Same. I do too.
Right? We have a lot in common. And today's episode is about it's not a disease. It's a medical thing that happens. Can happen to bariatric.
It's a disease, yeah.
Okay. Yeah. So the interesting story to our conversation today, which is about Wernicke's disease, and how Emma helped me remember this, is we say, we're not going to get Wernicke's disease.
Yes, we're not going to get Wernicke's encephalopathy. Yeah.
We're not going to do that.
Yeah.
And when I first met Emma, when I first met you, you had told me about this research, and it really went over my head. I didn't understand it. I was like, sounds amazing. Cool. Well, then at this year's ASMBS, you and your team, your colleagues presented a paper on what this is, how it happens, and what patients can do and clinicians can do to avoid it. So learned about it at ASMBS. On my flight home from DC, I was sitting next to a woman, Melanie and I were, and we struck up a conversation. And this woman said, my friend had bariatric surgery, but she is in big time trouble. Things are not going good for her. These are the symptoms that she's experiencing, and I'm really concerned. And she said, I can't remember what it's called, but it starts with a W. And I said, Is it Wernicke's? And she goes, oh my God, yes. And we had a 30-minute conversation about what this is. I passed your paper on to her. So even though it's not a super common thing, it's common enough to warrant us learning about what it is, what causes it, and how we can avoid it or treat it once it's been diagnosed.
Yes, absolutely.
Right? So that's what our conversation is going to be about today. We're also going to explore what other things we can do as patients and providers to ensure that we're set up for success in the pre-op stage of our journey, and things to just be aware of in the first few months post-op if things were maybe not going in a direction that we wanted to. And then, of course, we get to share that Dr. Patterson is a new practice partner of BariNation.
Yay.
I know, yay! We're thrilled about it too. So lots to talk about today.
Yes.
Before we dive in, will you introduce yourself to our friends that haven't met you?
Yeah. So Emma Patterson, and I'm in practice here in beautiful Portland, Oregon, where I have been for 25 years and focused my practice on laparoscopic bariatric surgery. And was actually the first in the Pacific Northwest to focus their practice on that. Straight out of my fellowship, which was at Mount Sinai Medical Center in New York, with the famous Michelle Gagne, who's bariatric surgeon and other things. And I did a lot of foregut with Dr. Barry Selke, and even did things like living donor nephrectomies, taking out kidneys for people who are donating them to family members. Learned those from Michael Eadie. And so really when I first got in practice, I did all those things, lots of variety. But really, my passion has always been bariatric surgery. And I went to New York to learn advanced laparoscopic surgery, where we make small incisions and we puff up the abdomen with carbon dioxide, and it's kind of like video game surgery, honestly. And really went to learn that because I could see in my residency training, and I did in Vancouver, BC, that it was definitely better for patients with things like gallbladders and hernias, and I really wanted to be an expert in that, and went off to do a year in all kinds of laparoscopic surgery, and that's where I really developed my passion for bariatric surgery, where I saw that I could do one surgery that could help and follow patients, of course, and educate them and counsel them, but one surgery that could help a patient, give them a tool to help improve their quality of life and their longevity. That there's good data now, as that we help people live longer by preventing serious things like heart attacks and strokes and many kinds of cancers. So I really fell in love with it from that medical aspect, that it was really wide open for research. Technically, the surgery was challenging, which was fun. And really, I like that long-term follow-up, getting to know patients over 10 and 20 years and not just, take your gallbladder out, see him once and you're gone. You never see him again, So
Yep.
It's really a special kind of relationship, as in the whole field of bariatric surgery, right? Between surgeons and our teams and our patients. It's much more of a tight, close-knit thing than you see in other kinds of surgery, I think. So that's kind of professionally what drove me to bariatric surgery. The funny accent, I'm from England. My dad was Irish. I spent a lot of time there, and I moved to Canada when I was 12. I've lived East, West Coast, Canada, and the U.S., so no one ever can guess where I'm from. So that's the short story. I'm a mutt.
But I love it. Your family tree follows my family tree, and I think that's why we have a lot of fun when we get together.
Yeah.
So I have a challenge for you guys listening or watching this podcast. One of the things I'm going to link in our show notes is Dr. Patterson's CV. And the reason I'm going to do that is you are going to have a hard time believing that the person that I get to talk to today is so accomplished, has done so much research, has done so much for the advancement of bariatric medicine. It's overwhelming in the best possible way because you really have spent your life researching this disease and finding the best pathways for care that possibly exist for patients. And not only do you do that in the operating room, you do it in your practice, and you do it for people who are experiencing serious medical complications in your advocacy work that you do.
Yeah, thanks. Yeah, I think when you're referring to some of my expert witness work, and that's really how I became known as an expert in Wernicke's, is I do serve as an expert in bariatric surgery and some general surgery, and now specifically a lot in Wernicke's, where there's lawsuits alleging medical malpractice. And so I might be on the patient or plaintiff side, helping them try to get some kind of restitution, or I might be consulted by the surgeon who's defending themselves. And, the job is really to look at all the records and be objective and be honest and say, no, this was fine, or no, this was negligence, and just be courageous and tell the truth. And turns out I have a knack for that. Weird. A little too much sometimes. That's the British part, I think. So that's where I really fell into the Wernicke's. In fact, the first time I was consulted about a Wernicke's case, they had told me or pitched it to me that it was something totally different that is more rare than Wernicke's, and which was super, super low thyroid. And so it's called a myxedema coma. And like, we literally never see that. But I looked at the records and I was like, no, this isn't that, but it's Wernicke's. This is what it is. And it is negligence, but it's not the thyroid thing. It's Wernicke's encephalopathy. And so then I just, got known and started publishing in this area and getting more and more cases in that area. And so the paper you were mentioning was, we formed, under Dr. Marina Kurian's leadership last year, was our president of ASMBS. We talked about Wernicke. She saw the need for a task force in our society. So she formed this ASMBS Wernicke's task force, which we're both on. She put me in charge of it. And my co-chair is Nate San, an excellent nurse practitioner. And we have many excellent physicians, dietitians, psychologists, psychiatrists on our task force. And we've all worked hard to really review all the literature. Our mission really is to educate and then prevent. So we did a big literature review on Wernicke's and bigger than bariatric surgery, looking at bariatric surgery, but it affects patients in other areas too, which we'll get into. And now we really want to spread the word. So that paper got published in SWORD, which is, our official journal of ASMBS, in July. And now we're just finishing up a education module that'll be available on the website for credits and for people to help educate others, and a few other little projects that we're going to do. But we're very proud of this paper, and that will help to start to change practice. And we're going to do a quality improvement project that people can make it sort of available, that they can just plug it into their practice to look at thiamine deficiency and preventing Wernicke's. So that's probably going to lead us into what Wernicke's is.
Bingo. That was going to be my very first question.
Yeah. So Wernicke's encephalopathy is an acute neurologic, in fact, neuropsychiatric syndrome from a vitamin deficiency. And the vitamin is thiamine, which is also known as vitamin B1. It was the first B vitamin discovered, I think, in the early 90s, 1900s, I should say. And if you don't get enough, it leads to neurologic problems, which then that's Wernicke's encephalopathy, and it can be treated with high doses of thiamine. But if it's not treated in a critical window, which seems to be around 3 to 6 months of showing the symptoms, then they become permanent. And that version's called Wernicke-Korsakoff syndrome. That's even more serious. And then there seems to be no treatment and no improvement, and patients can end up really permanently disabled. They go from being high-functioning people like you and I to having no energy, having trouble walking, maybe bedbound, not able to drive, not able to feed themselves, to pick up metal utensils, and problems with their cognition, particularly short-term memory issues and executive function issues such as decision-making and calculations. And then a classic thing that is known is that because they're forgetting things and they know actually and they're embarrassed, they'll then fill in the gaps by making things up, and that's called confabulation. Yeah.
Ooh.
So it starts out as, thiamine deficiency, which if it weren't for fortified foods in the U.S., would be rampant. Probably around 40% of people would be deficient in thiamine if basic things like flour and cereals and infant formula weren't fortified. So we're generally not getting enough from our diet, and you can get it in your diet from things like pork, beans, salmon, some grains, some vegetables. And so that's very important to have a healthy, varied diet. Things that reduce your thiamine are actually a high carbohydrate diet. So carbs take more thiamine to metabolize. And that's probably why, at least that's a hypothesis, why so many of our patients who are having bariatric surgery actually deficient in thiamine before surgery. So the study's showing that up to 30% of patients are low in thiamine before surgery. And so that's what you'll see in our guidelines. One of the main differences from prior ASMBS guidelines that focused on, all of nutrition or the micronutrients, so papers from like 2016 and 2020. One of our big pushes is prevention. So anyone who's going to undergo metabolic and bariatric surgery or try to lose weight from anything, but particularly now these medications that can produce some pretty rapid weight loss, such as the GLP1 meds, should be starting a high-dose oral thiamine 2 weeks prior. So the new recommendations are 100 milligrams a day, daily for 2 weeks before surgery or before starting medications. And that is generally not happening. So that's a big change. And then continuing that dose of 100 for at least 3 months after surgery or after the medications, because it's so preventable if you just take it orally.
Right.
Yeah. The prior guidelines were very good, and that said take at least 12 milligrams of thiamine, which is typically what's in a bariatric vitamin. Over-the-counter vitamins typically just have 1 milligram, and because apparently the daily recommended amount is only like 1.1 or 1.2 milligrams for women or non-pregnant women, and men, pregnant women need a bit more. But I actually wonder, I suspect that guideline is not correct, and I'm going to look into that. Probably we need a bit more since everyone is so deficient. I don't know. But definitely if you're not eating much or you're at risk of vomiting, it's just best to take more. And so thiamine, it's an essential vitamin, meaning our body doesn't make it. You have to get it from food or a vitamin. And the body doesn't store much, just 30 to 50 milligrams, right? So if you need one a day, that's only a month or two at the most. It has a short half-life, meaning if you eat some, then it takes not long, like a week later, it's half gone. So it's a very short half-life or turnover. So essentially, you can get depleted in just 2 to 3 weeks. Yeah. And so
that's scary.
Yes. And so some practices that this is actually mind-boggling to me, and hopefully they're going to change. But sometimes I'm reading these records from when I'm doing a case review for malpractice, expert witness stuff. Some practices aren't telling the patients to even start vitamins for 2 to 3 weeks because they think it causes nausea. But it doesn't, because I've been giving patients vitamins and higher dose thiamine for years, and we're not getting any calls for nausea. In fact, thiamine deficiency causes nausea. So it's much like dehydration, right? So dehydration is, or nausea is both a cause and a symptom of dehydration, right? So you get nauseated, you don't drink much, you get dehydrated, and it's this whole vicious cycle. And then you get more dehydrated and more nauseous. It's the same with thiamine. Thiamine deficiency causes nausea, then you're not eating and drinking much, you're not tolerating your vitamins. So thiamine deficiency can cause vomiting by itself without, even if you've got a perfect stomach. And so this is what I see happening in the cases I review is sometimes I think some surgeons just get focused on just anatomy. We're doctors at the end of the day as well as surgeons. So we're responsible for the physiology and the nutrition as well, right? Since we're the ones making it so that patients can't eat very much through either surgery or medications, we really have to know, be aware of the vitamin deficiency emergencies, of which really this is the only one. It's not like, there's other vitamins that can get deficient, but essentially this is the only one that's a life-threatening emergency. So we really got to be up to date on it and prevent it by just giving it orally.
Yeah. Let me just recap this because this is a lot.
Yeah.
So thiamine or B1 is an essential vitamin and nutrient that our body needs, but our body doesn't produce it. So we have to ingest it.
Yeah.
In the United States, we have a carb-heavy diet, but we also have foods that have been fortified or where B1 and thiamine has been included in that food product.
Yes.
But the higher carb intake takes more of the thiamine. So even though we're ingesting it, those carbohydrates are asking our body to burn what we're taking in at a higher rate.
Yes.
And then we're left depleted just as a society.
Yes.
And as we're getting ready to have bariatric surgery, this is an extremely important thing to know and to have your level checked, because it can quickly impact your health after surgery when you are not consuming foods that possibly would have that fortification, and you're just consuming less as you're recovering from surgery.
Yes, and that's exactly very good, April. Yeah, and you mentioned, actually, you raised a key point of getting your level checked. That is still we didn't recommend that in our new guidelines. That is in prior SMBS guidelines on micronutrients. That, they list off a ton of blood tests to do. Thiamine is one, and I think it's wise to do that. And I wouldn't tell anyone not to do that. I personally don't do that because I'm just giving everyone thiamine anyway. The test isn't a normal one. Doesn't mean you're not deficient. A low one means you are deficient. But if you're just going to give everyone 100 milligrams a day for 2 weeks, you're going to fix, really, as long as they're able to eat, you're going to fix any deficiency. So I think probably the best thing would be, test the level and treat for 2 weeks. But to me, it seems a bit redundant and that costs money. So I just treat everyone.
Okay.
And you can, you can get, doctors can prescribe thiamine, or you can get it from one of the bariatric vitamin companies.
A specific one.
Pardon me?
A specific one. So you can.
So this is what, I use. So here it is. This is what I take. I've got one here on my counter to take home today. Where is it? Thiamine 100. So,
Okay.
Buy it right on our website. So that's what I take, and we give out to patients when they first come in. So there's 90 in here. So we just give them a bottle when they're coming in for their, their kind of their scheduling visits.
Yep.
It's like, here you go, start this. Yeah.
Okay. So this is a part of your pre-op and post-op protocol.
Yeah. Pre and post-op. And then, so we call that, so we've in our paper put the thiamine deficiency and Wernicke's in a common kind of public health paradigm that's used for other diseases of primary, secondary, and tertiary prevention. So primary prevention is when you, try to prevent disease in people who are high risk or susceptible. So that means anyone who's about to knowingly try to lose a bunch of weight and not eat very much. So that means give 100 daily in patients before bariatric metabolic and bariatric surgery and medical weight loss. So that's the primary prevention. Then we get into secondary prevention. So that means treat early when subclinical. So in this case, that would mean someone's thiamine deficient, but they don't yet have Wernicke's. And so those symptoms of thiamine deficiency can be a bit vague. So you've just really got to be on the lookout after bariatric surgery. So it's nausea, vomiting, weakness, low energy. And so then if you have a patient having any of those kind of symptoms, which really it's not normal to have any vomiting after surgery, then you need intravenous thiamine. So we call that the banana bag, right? This looks yellow because the thiamine's yellow, and you need 100 milligrams in your IV. So for a day or 2 or 3, or until the vomiting stops, or whatever the high risk thing is. Usually it's vomiting. And so we're hoping that people adopt this protocol that we're trying to push. And hey, if your patients are coming to the ER, we're actually going to make a new ER poster to send out. Because this isn't just bariatric patients, but anyone who's vomiting really should be getting a banana bag. This can prevent the Wernicke's.
Okay.
And so the things that thiamine does in our body, which then will help make sense what the symptoms are 3 main things. So it helps produce energy, or ATP, if you remember that back from biology, biochemistry. So thiamine is in the good old Krebs cycle for producing energy. So they just feel low energy everywhere. Okay. And it's also involved in cell growth and function. So it affects the whole body. And then it's also involved in what's called myelin sheath maintenance. And myelin sheath is the white matter. It's like the stuff lining the nerves. So electricity, jumps along the nerves quickly, and your nerves are all firing fast, like mine are today from 2 coffees. And so without that, everything gets slow and sluggish in your nervous system. And so that kind of leads to the classic symptoms of Wernicke's, which are eye signs, so blurry vision or double vision, confusion, your brain's just not functioning well. And that can be quite subtle, that maybe only the family members would notice, someone living in the home, but not the doctor at a 5-10 minute visit, that they're just really quiet. They're not getting out of bed. They're not having a conversation, So it can be pretty subtle. And then ataxia, which really means uncoordination, affecting, from like the brainstem white matter, but classically that's with regard to walking. So an abnormal gait, a patient's legs feel like lead weights, they have trouble walking, and they kind of walk like they're a bit intoxicated. It's more of like a wide, and so you have to walk with your patients to really diagnose this. And so they walk kind of wide-legged, slowly, not swinging their arms very much, and you have to go around corners with them because they'll tend to lilt to one side. And so when you actually make the diagnosis of Wernicke's, it's an emergency, and they have to be admitted to hospital at that time. So now that's into tertiary prevention. So that's trying to limit the long-term consequences once they have the disease. If you treat it now, they can get totally back to normal and not go on to the Wernicke-Korsakoffs. So once you make the diagnosis, the patient has to be admitted to hospital and get high-dose IV thiamine. So now it's intravenous 500 milligrams 3 times a day for at least 5 days.
Wow.
And the interesting thing that I think a lot of people don't know, I think most people, if you ask them about Wernicke's, they'll think back to med school and they'll remember that triad. And they remember that can occur in people with alcoholism. So people with alcoholism also aren't generally getting enough nutrition. So they're at high risk. So those really are the top 2 risk factors these days: alcohol use disorder or metabolic and bariatric surgery. Wow. And so there's some other conditions where people aren't getting enough to eat, or they're vomiting too much, such as in pregnancy. Some women vomit a lot. It's called hyperemesis gravidarum. That's another condition where they get it, where they're just chewing through all their energy and thiamine quickly, like sepsis or trauma or hyperthyroid, and then other gastrointestinal things that would make you not absorb or vomit. And so to make the diagnosis, getting back to that, you really only need one of that triad. So you need what's the diagnostic criteria now that have been validated and widely accepted are called the Kane criteria. And you need 2 of 4 things, but one of them being dietary deficiency. So all of our patients have dietary deficiency, certainly in the first 2 months after surgery.
Yeah.
And then you need plus 1 of eye signs, confusion, or ataxia. So you got to be on the lookout and then admit them to hospital, treat them. And I have treated a few patients myself, and it's the closest thing to a miracle that you will see. Someone's come in, they're 6-8 weeks after bariatric surgery. Maybe they went away on holiday to recuperate. They got sick. They were vomiting. They come back to the ER. They're confused, trouble with finding their words, can't walk very well. Family thinks they've had a stroke. Hopefully someone makes a diagnosis of Wernicke's. You send off a blood level, which is somewhat academic, but you can't wait for the blood test because it takes 5 days to come back because it's a specialized test.
Oh, and by that time,
whole blood thiamine within 5 days. I mean, they could be blind or deaf literally by that point.
Yeah.
You send that off, you treat immediately, and then within a day or 2, they'll start to clear. Their speech is better, their word finding, and they'll go from bedbound to walking. And that's what I mean by closest thing to a living miracle that you'll ever see. And I've seen that a few times. It's amazingly impressive.
Wow.
Yeah.
Well, and it's so interesting to learn about this, right? Because on the surface, it seems very simple. And in some ways it is, but the damage that can be done by not understanding why your body needs these, why vitamins and why preparing for surgery is so important.
Yeah.
It kind of baffles me when I think about my pre-op education that I got. you were the first person that told me about this, and I was 5 years post-op at that point, right?
Yeah. Yeah.
And from my layman's perspective, right, the symptoms of it could mirror other things that are going on, but to delay treatment is extremely detrimental to a patient's life.
Yes. And the thing is, there's really no risks of thiamine. There's been very few allergic reactions, but as long as when we're giving it, you dilute it in the little 100 ml bag, and patients tolerate it just fine. So there's really no risk. And so the best really test for Wernicke is an actual trial of thiamine, because you see they've got these neurologic signs. You admit them to the hospital. Your colleagues are thinking, that's a maybe Wernicke's. And it's like, no, you're like, this is Wernicke's. This is not possible Wernicke's. This actually is Wernicke's. I put it in the chart. Chief problem, right? Principal problem. Try to educate everyone on my notes about it. Really is Wernicke's. Then you give the thiamine, and then, lo and behold, the patient's better. But interestingly, it seemed like some doctors still are in such denial. Like, I've admitted them to hospital. Medicine's following them. They're getting better. They've scanned their head. The CT scan's always normal. MRI would be abnormal about 50% of the time. CT's normal. They don't have any other working diagnosis. It's clearly not a stroke, which a CT would show. I'm giving them thiamine. They're getting better. And yet the other doctor still doesn't actually believe it's Wernicke's. Well, how do you think they went from not walking to walking in 3 days? What other treatment did you do? Was it that PT once a day? I don't think so. So I'm just trying to educate, like, one-on-one and en masse,
Right.
But it's pretty impressive when you see it. And then the key is, like, you have to, once you admit the patient and treat them, you have to actually examine them each day. Like, you check for nystagmus is something they can get on exam. And that means your eyes, like, flicker to the side. So you have to, like, follow your fingers. And there's a few tests we do for coordination, but the eyes will flicker. That's a common sign. And then you have to actually walk with them each day. And you'll notice their gait getting better each day. And so really the treatment, and the patients start getting impatient, as do the doctors, because they're so much better. But the treatment really is a minimum of 5 days, or until no further improvement. So if they're still getting better, you want to keep them in hospital as long as possible, getting this high dose thiamine. And a key thing too is you have to replete several other things along with it, particularly magnesium, because thiamine needs magnesium to work properly in a lot of these biochemical pathways. So they'll often be low magnesium. So you have to also replete the magnesium. And then often they're having it because they're somewhat malnourished, and you have to prevent this refeeding syndrome by also giving a phosphorus too. So you've just really got to fully replete them nutritionally. And then when you are ready to discharge, feeling that, okay, they've really, plateaued, they're 100% better, or they're 95% better, then they have to stay on pretty high. It's best to keep them on pretty high dose oral or like an IM injection every week or two. Injections are fairly painful, so I've only had a few patients really keep up with IM injections where they're really trying to prevent relapse, and you have to follow patients closely after they go home from hospital, because they can relapse. They'll call and say, hey, I'm having word finding again. I'm falling. I'm stumbling again. I got numbness and tingling in my legs or signs. And so then you either get them back in the hospital, or sometimes then you can treat when it's kind of a little bit of a rebound as an outpatient with like a once a day high dose and like plus oral high dose. But that's something you've really got to watch out for. Sorry, getting a message from my kid who's sorting out his apartment in London here today. It's a big day. He's got a couple questions, but we'll get to that after. Sorry.
Hey, life of a surgeon, a researcher, and a parent.
Right. Yeah.
It never ends.
Yes. Yeah. Okay. So then when they go home, you want to keep them on it. Yeah, so magnesium, phosphate, and potassium you got to watch out for. And then our new guidelines say give them 300 orally, like 2 to 3 times a day. So pretty big doses orally until their risk factors have resolved. And then they would, once they've had Wernicke's, go back to kind of the 100 milligrams a day indefinitely.
Yeah.
But we like to, to kind of try to get this message across to the surgeons treating the patients or preventing it. It's kind of like there's a lot of emphasis in all kinds of surgery on preventing blood clots, right? Preventing blood clots in the legs that can go in the lungs and be fatal. Big push for this over the last 10, 20 years. I think a lot of people are paying attention. We do an individual risk assessment based on a few things. And, so primary prevention, everyone's getting the leg squeezers and maybe 1 or 2 shots of blood thinners in the hospital, right? And then if you're higher risk, you're going to go home. So maybe you've already had a blood clot or you're on estrogen or something. Then you're going to go home on blood thinners for shots for a month. So that's kind of like the secondary prevention. And then, but when you get the disease, so now, we've tried all these things and you've still got the blood clot, then that's an emergency. Then you're to the hospital with high dose, right? So it's kind of similar to that, except of course, with giving blood thinners, there's a risk of bleeding. This is very similar to that with thiamine deficiency and Wernicke's, but there's no risk of thiamine. So we should be very liberal with it.
That was my next question. Can you have too much of this or too much? Okay. So if your body doesn't need it, it's just going to evacuate it.
Yeah.
Right. Mm-hmm. But okay. And I guess I'm just thinking like from a patient perspective, right? If you're pre-op or even if you're post-op and you're worried about this, is it the thing to do? Like, should patients go into their pre-op appointments or even their post-op appointments and say, hey, I watched this cool podcast on Wernicke's, learned a lot about it. Is this something that we can check for? Or what protocol do you recommend that I follow based on the research that's been done?
Yeah, I think it's always good. Anyone watching to discuss it with their own bariatric surgeon, but there's no contraindications to thiamine. I've never seen any interactions with any other meds. So, we intended our guidelines to be used and read by everyone, not just bariatric surgeons, but by patients and ER doctors and neurologists and OB-GYNs and cancer doctors. So we want everyone to be familiar with these. And it's perfectly safe for patients just to go ahead and buy it and start taking it 2 weeks before surgery. I'd rather them do it on their own than wait for the approval for someone else because there's no risk to it, honestly.
Gotcha. And is this something that we can experience post-op, like 1, 2, 3, 4 years post-op, or is this something specific to a timeline?
Yeah, so it can occur at any time. Now, there's a few case series of reviews of Wernicke's after bariatric surgery. And classically, they're vomiting for several weeks after surgery, maybe from some other complication like a stricture after a sleeve or ulcer after a bypass or something, or bowel obstruction. And they're starting, so then they're getting symptoms of thiamine deficiency by 2 to 4 weeks. And then classically, if they're not repleted, then they're going to go on and get Wernicke's at about 2 to 3 months after surgery is the peak time. I find right around 2 to 3 months, patients have Wernicke's, and then, and I think most people are doing a good job of preventing and diagnosing it, but we're seeing too many lawsuits from it. I think because it's getting missed sometimes. Yeah. Either the diagnosis isn't made, or sometimes even it is made and then it's undertreated. So they make the diagnosis, and I think one doctor thinks the other doctor's ordered it, or they're ordering just the 100 milligrams, which is, that's that secondary prevention. That's before you've got Wernicke. So it's not enough. And I've seen many cases where actually they do make the diagnosis, then they undertreat. They're given the 100 a day instead of 500 3 times a day. And they're getting progressively neurologically worse with, leg pains, numbness and tingling, worse walk, worse neurologically. Even I literally have seen patients go blind or deaf, have bladder problems, urinary retention, where they're not peeing, and then even goes on to incontinence, urinary incontinence, bowel incontinence. That sadly, all these things can be permanent, are permanent if not treated quickly and appropriately with the right dose.
Yeah. Well, I mean, the woman we were sitting on the airplane with, she just really kind of said, I think my friend's getting better, but it's not good. And, I'm really scared. And it seemed like there was just a lot of confusion around what she was experiencing. And that's scary, right? Because this is something that should be known by patients and providers. It should just be a part of kind of the pre-op education, maybe just to be made aware of it. Yeah. And something that is discussed ongoing. And yet another reason, right, why as patients, we hear all the time, you got to take your vitamins. You got to take your vitamins, right? Yeah. And this is part of the reason why our vitamins are so important. We could be deficient before surgery just because of our diet, and we can continue to be deficient, if not so, after surgery because of the type of food, the quality of food, the frequency, the amount of food that we eat. Yep. It might not be possible to maintain a healthy level through nutrition alone. Yeah.
Yeah. Exactly. Yeah, you've got to keep up with it. And I mean, you can go on with Wernicke's and you can go on to have seizures and die. I mean, it can be fatal. Yeah.
No, not something
preventable with one little capsule a day.
Right. Yeah. So are the multivitamins, right, that are out there for the world, or the specific multivitamins or vitamins that are built for bariatric patients, do they meet kind of the threshold for patients to stay ahead of this? Or
so I'd say the over-the-counter vitamins, no, they're not enough in bariatric surgery. Generally the bariatric vitamins have at least the 12 milligrams, kind of 12 to 30 milligrams. So those, in the previous guidelines, those were adequate. Now with our guidelines, not for that initial phase, that 2 weeks before surgery or weight loss medications to 3 months after, that most rapid weight loss phase. You need that extra 100 milligrams. And then you're perfectly fine. You're eating enough. You could drop back to a bariatric vitamin that has at least 12 milligrams.
Okay.
I personally the more and more terrible cases of Wernicke's I see, I just tell my patients, just stay on the 100. But really, each time I see a patient in follow-up, I'm going through which vitamins are taken. And then specifically when they say, multivitamin, I'm like, okay, which multivitamin? Because if it's an over-the-counter multivitamin, they're definitely not getting enough thiamine. And then I'm like, okay, just take this, either just get it here today, or I'm going to prescribe it for you. And so you've got to know which multivitamin they're taking. And, your question about can it happen years later? So most of them happen in that first 2 to 3 months. But I have had patients, because things happen later, right, that affect their eating. So say I've had patients who've had really any kind of surgery, but say I've had patients have a lap band and then they move away and then the band's too tight and they've been vomiting. They haven't seen me in 5 years. And they come back to town and I'm like, oh, you got Wernicke's. Let's loosen your band, give you some thiamine here. We're going to stick you in the hospital. So I've had that. I've had patients who, they move away or get lost to follow-up. I've had a patient call me. Again, they don't know what's going on. They're weak. They're dizzy. They've tried all the other doctors. They've had a bypass. They haven't been in 5 years. They're not taking vitamins. And I'm like, examine them. Like, oh, Wernicke's in the hospital. You go.
Yeah.
And same with the sleeve. So it can happen with any of the surgeries, whether, they're a band, a sleeve, a bypass. With the more malabsorptive kind of surgeries, we're seeing, that are less common overall, but we're seeing a bit more as the revisions now with, the more malabsorptive things like the duodenal switch or SADI-S. Really got to be careful. And I would definitely have those patients stay on 100 forever. Personally, I don't do those more malabsorptive operations because of the other vitamin deficiencies too. They just concern me. But you just can prevent it with a capsule a day.
Right.
Yeah.
I mean, it seems like a a simple solution to something that I think we all want to avoid, but sometimes knowing the why behind it, understanding why our body needs that nutrient, what it's doing with it, helps us stick to a regimen that our doctor has prescribed for us.
Yeah, like, I need it for all my energy, cell growth, and maintenance, and all my nerves. You pretty much can't get more important than that, right?
Right? Yeah.
Yeah, and then without it, I mean, it causes heart failure. It's called wet beriberi. You can get heart failure from it, and there's studies showing that higher dose thiamine actually can help patients with heart failure. And there's randomized, I mean, I think this is really going to hopefully soon become known as the new wonder vitamin, but there's randomized studies showing that how it can help diabetes control, sugar control with diabetes at higher doses. It's not really exactly known how, but good data on that.
So question now. Yeah. Dr. Patterson, if somebody's had bariatric surgery and they have onboarded a GLP-1 medication, does this represent an opportunity for Wernicke's to be an issue again?
Yeah. So, I've had, I've been doing this 25 years. So some patients, they sometimes gain some weight back. Then we're like, what are we going to do? Sometimes another surgery. So now we have some meds that work a bit better with the GLP-1 analogs. And so you can have a patient then get another rapid drop in weight loss, or then again, at higher risk for Wernicke's. So again, I would say our guidelines apply to that situation too. So anyone, if you're going to start a new weight loss medication because you've plateaued or gained, you may be then expecting to have a big weight loss drop. Mm-hmm. Go on your 100 milligrams of thiamine a day 2 weeks before you start that medicine, and then for at least 3 months or while you're in the rapid weight loss phase. Absolutely. And we're seeing more and more of that. So everybody's just got to be aware. Yeah.
And I think why it's so wonderful that we can have this conversation with you, right? You're seeing the impacts of this from your provider standpoint. But you were also interacting with these impacts in that advocacy work, right? In that consulting work that you're doing. Mm-hmm. Mm-hmm. And to be able to step even out broader and say, look, this is not a bariatric issue. This is like a human health. This is a nutrition. This is an everything issue. Yeah. It puts a different emphasis on that, right? Because I think sometimes as patients, we get tired of hearing, well, you have to do this because you're a patient. And you're like, cool, one more thing that I have to do because I'm a patient. Yeah. But to just know that, no, this is something that you should be thinking about or talking with your doctor about because you're human. And you want to live a long, robust life. And this is just a part of it in our modern day life, right? Our diets have changed drastically, even in the last 100 years. And you're starting to see the impacts of the changes, right? Of modern society being reflected in our health. Yeah. And it doesn't have to be a scary thing if you take the time to really understand why our body needs these things and just what we can do to avoid them. Yeah, exactly. Yeah. And again, another reason to continue to be connected to your care team. Yes. Right? You really, when you are making the decision to have bariatric surgery, and sometimes you don't have an option, right? The only surgeon that your insurance covers or that's in your area is the surgeon that you choose. And it's going to be a good experience, right? But as a patient, taking the time to educate yourself about all of the things that are going to go into this and then continuing to lean into your care team for the rest of your life is critically important. Right? You didn't choose to have the disease of obesity, but now that you know you have a disease, you have a lot of choices that you do need to make. You have a lot of decisions that come with that. The reward for you staying on top of it and making those decisions and having those conversations is you have a wonderful quality of life. You have an improved quality of life. Yeah. And right, sometimes these little things really do make all of the big difference. Yeah. And as long as you're taking the right vitamins, you're going to prevent, the treatment for one disease of obesity leading to this other equally as serious disease of Wernicke's encephalopathy and Wernicke-Korsakoff syndrome. Yeah, this kind of reminds me. We've been batch recording podcasts this week, and I feel like I've had 50 conversations with amazing people. But the theme of these conversations, one of the themes has been, it's so amazing that one surgery, bariatric surgery, can help with so many negative health things, right? It's like this one thing does all of this. And I kind of feel like this is the case with B1 with thiamine. This one vitamin helps with so many things.
Yeah, it does. Yeah, because it affects your whole body. Yeah, right? And the one procedure helping so many things, I was saying, I mean, that's why I went into this field. That's why I love this field.
Yeah.
Thiamine is, it's very important. The most important, I would say. B1 for the brain, you know. We're not going to get Wernicke's. B1's for the brain. Yeah.
I love it. All right, the last question about this, and then I want to shift gears a little bit to other pre-op stuff. But I have heard before, and we've heard from our experts, right? Some vitamins are water soluble, some vitamins are fat soluble. Mm-hmm. What does that mean? And what's the best way to take a B1 vitamin?
Okay, so generally the fat soluble ones are just the they're A, D, E, and K.
Okay,
so those are absorbed in the lower part of the small intestine.
Okay.
Most others, so thiamine is absorbed more in the proximal or the first part of the intestine, and it doesn't need. I mean, the beauty of it doesn't need any special way of taking it or things to avoid. So like, you probably were thinking of like for your iron absorption, you got to try to not take it, which is the most common vitamin deficiency we see is iron absorption. I could talk for hours about that too another time. That's the most common one, which also causes a lot of things.
Stay tuned for part 2 on our vitamin series.
We'll come back and talk about iron at the time. But so for your iron absorption, you don't want to take it with calcium, or the calcium and iron, it stops the absorption.
Yeah.
Thiamine is so well absorbed that it doesn't, nothing strange like that happens. So it's absorbed in the intestine, and then it biochemical things happen to it, and it quickly goes through the, gets attached to the red cells and goes throughout the body to the liver, the heart, and the muscle, and then it goes through the blood-brain barrier, through the cerebrospinal fluid into the brain. So it's very water soluble, and it really absorbed easily when you take it. Yeah, so it doesn't need anything special. Mm-hmm.
I mean, awesome, rad. You know what I mean? Like, okay, that's yes. It's another thing to know. It's another thing to have stored up here. Yeah. But it's really good to know that it's a very accessible tool that we can use in our toolbox to ensure lifelong overall health. That wraps up another empowering episode of the BariNation podcast. If you enjoyed today's episode, keep the conversation going by joining the BariNation membership community, where you can attend live support events, access on-demand resources, and find a caring community.
Join us at barination.mn.co. If you found this podcast valuable, help us produce it by becoming a $5 monthly supporter at barinationpodcast.com.
And just remember, at the end of the day, you've got this, we've got you, and we'll see you next time. Bye, everybody.